write your questions in the chat section and we will get going. So I always like to start these off with a specific question on what we get the most when it comes to the back on track. Probably the biggest problem that we get on actually having calls in as to what's happening with it is if you leave the back on track on overnight or during off clinic hours, especially over the weekend or something like that, and you get an electrical storm come in, boy, it can really mess with the electronics in that piece of equipment. So I highly recommend that you turn it off right there where the the power cord plugs in. Turn it off during non-clinic hours. That way, if you get a power surge, the electronics are relatively safe. And the other thing is that with the back on tracks, it comes with the APC battery backup surge protector. And that has about 300 watts of power. Really should be reserved for the back on track only. Okay. Don't plug anything else into it. That's very important. All right. We got Dr. Alan Cross, Dr. Farkas, Gabor, Jared. Linda is on board today. Liz, Dr. Michael Clancy, Dr. Robert Cowan, and of course, JT. He's keeping track on making everything head in the right direction. So again, in your chat section, or if you want to raise your hand and you have a microphone and a video, then I can pop you up and you can ask your question. But please, in the right-hand corner, if you look down at the chat section, it will actually allow you to type in any questions that you may have. Let's go over some frequently asked questions. Typical treatment protocols, plans for the back on track is 24 visits, 3 times a week for 8 weeks. I highly recommend that you start off at depending on the patient's height, let's say someone's 5'2" to 5'5", typically start them off at about 2.5 inches. And every 4th visit, I'm going to reevaluate and add a 1/2 inch over the entire treatment protocol. So on the 8th visit, I'm going to reassess. If I start them off in straight axial decompression and distraction, like protocol B or protocol C, then I'm going to move them into bilateral or unilateral movement as fast as clinically appropriate. Something like protocol K or M or protocol U. I'm always pretty much headed everybody towards getting protocol U out. Okay, that's where I want them to go. Let's get some more. Hey, we got more people joining. It's awesome. Guys, ask questions. At the bottom, you see the chat. Hey, Dr. Tiffany Miller, Dr. DeSalvo, Doug Penrose, Donnie Chris is on board. He wants to make sure he gets everything up and running so you can get the very best of what we have to offer. So again, if you have any questions, which I know you all do, in the chat section at the bottom, just type in a question. If you want to do a private, you can do a private question as well. If you don't want to, if you have some questions like that, then by all means, please do. So I was getting back to the progressive protocol. So if I start somebody up in protocol C at 2.5 inches, protocol in 4 visits, I'm going to reevaluate at a probably a 1/2 inch. And I'm going to move them into a lateral movement as soon as possible. That lateral movement may be unilateral or bilateral. I can tell you somebody that has a spondylolisthesis, spondylolysis, grade 1, grade 2, grade 3, those individuals typically do not like to be axially distracted intermittently. They do pretty good with static axial distraction, but they don't do well with intermittent axial distraction. And that's the way that structure is actually working. The quadratus lumborum, the shear on the disc, the iliolumbar ligament gets really tight, and they do not like being repeatedly pulled. They do like the sweeping action of the bilateral movement on the back on track. So protocol M or protocol O can be very effective in those individuals, okay? So who has a question? Come on, guys, hit me up. What do we got going on? We got more questions. So other contraindications. Specifically, you don't want somebody that's got active bone cancer. or active cancer period. If they have uncontrolled diabetes, those individuals are not going to respond well to pretty much any type of treatment that you do, but specifically to axial distraction and bilateral distraction as well. So Linda has a great question here. It says, how would you treat scoliosis with the back on track? So let's say you got an S-curve scoliosis. You want to treat that with, you got to look at the curves, okay? So let's say there's a lumbar left scoliosis apex at L3. You basically want to diminish that curve. So you're actually, a left curve is going to basically put your feet left. So you're going to want to use a axial, straight axial, and then move feet right, okay? So any of the protocols that actually move the feet right, and then you can block in the apex on the right side. Then you have actually another aspect of that. So you can block, so let's say you have a thoracic apex curve that's right lateral. It's got a right convexity. Then you want to block at the apex, say the apex is at T8, and you want to block on the left. And then, so now you're blocking into the apexes with, say, SOT blocks, okay? And if you've got an S-shaped curve, you actually want to move feet both ways, okay? You start them off in axial, probably protocol B, and then move forward from there. Donnie, I know you always have a great question on spondylolisthesis. Again, I talked about that a little bit earlier, but spondies don't like straight axial distraction, intermittent axial distraction. They do like having the sweeping action of either protocol M or O, and then also protocol, like protocol U in the end is actually where they're talking about. So the scoliosis question is, I didn't have a tremendous amount of experience treating scoliosis. This wasn't exactly my forte, but if you have a functional scoliosis versus a structural scoliosis, you have to figure that out. You do that with your x-ray techniques and your exam techniques. Those are all important aspects of what's going on. Hey, we just had Dr. Shelley Draco, Dr. T, Dr. Jason Black. Definitely, if you have questions, put them in place. Let's figure out. I hear that you mentioned facet syndrome in the back on tracking. I'll elaborate on that. So facets, so anytime you do intermittent axial distraction and or lateral or bilateral movements, it really calms down the inflammation in the facet as well, okay? So the facet has type 2 mechanoreceptors in it. When you do type 2 mechanoreceptors, it actually knocks out a lot of the pain when you put them under distraction. There's not much that we do in our daily activities that creates axial decompression in the lumbar spine, thoracic spine, cervical spine. Okay, it's an artificial movement for us unless you fly into outer space. So one of the big things that you have to do is you have to create that artificial decompression. The chiropractic adjustment does do that, especially in side posture. SOT blocking can do it minimally, but not a tremendous amount. So we actually have to create that anti-gravity state, decompression state, when we're taking a look at what's happening. So very, very important that you use the back on track in a manner that actually is clinically appropriate, but things like facet syndrome, herniated discs. I don't know if you can even see this. We had a doctor actually send this in. Let's see if I can get you to see it. Now, do you see that L5S1 disc bulge? It's actually a protrusion. Okay. This patient had this in, let's see, it was February 23rd of 2017. Okay. And Dr. Moss sent this in to us. And he went through a course of treatment, chiropractic, myofascial release, physical therapy, and specifically back on track. And then about a year and a half later, he did another MRI, okay, and had a complete reduction of the protrusion at L5S1. That's pretty significant. I don't have the particulars on what this patient actually had, but when you take a look at the MRI, it actually looks like there's a right laterality there. So that's what's so interesting about what you can do with the back on track is that, say you got right sciatica, okay? You can move feet left, that opens up the right IVF, takes pressure off that bulging disc, and actually improves, diminishes the disc and the occupying space occupying lesion. Boy, I can't talk about that. So guys, if you have questions, I highly recommend. We got 18 people on so far. Awesome, awesome, awesome. Hey, Dr. Hamid, if you have any questions, please put it in the chat. Anything about protocols, contraindications, indications, whatever it may be. And then I'll be happy to answer any questions that you have. But again, we were talking about this MRI. This is really pretty cool. We just got this in. Went from a significant protrusion to a post-MRI about 18 months later that really, really improved. Pretty interesting stuff. These studies are out there. When I first got into decompression back in the early 2000s, one of the big things is that they wanted you to do pre and post MRIs. Well, you know what I did? I did a bunch of pre and post MRIs 2 months after I did treatment, and it did not look like these types of improvements. It actually, most of them either looked worse or absolutely no change. And the patients were not really happy with that. And it took me a long time to kind of put a reason why that might be together. And it just takes that much time for your body to actually heal the annulus fibrosis of the disc. You got to take the pressure off of that disc for a long enough period of time. And look, the outer aspects of that disc are fibrous in nature, so very slow healing. They don't have a tremendous amount they have zero blood supply to them. So it takes a very long time for those actually to start to heal themselves and pull that material back in and actually it stay in. And a lot of times those are positional in nature. So minimally, same thing that we have with the knee on track is that I minimally recommend that at least you do imaging 6 months from the initial start date of care. All right. So if you want to do a post MRI, I'd give it at least 6 to 8 months before you do a post MRI. You're going to see bigger changes, longer lasting changes at that point in time because it takes your body that much time to actually get it feeling better. Oh, let's see. So Jared, if the patient is in severe lower back pain with pain down back or right leg and antalgic to the left, what protocol would you use? So it's a great question. Let me grab my protocol list real quick. So you got pain down the right leg. So if somebody's got a severe stenosis, what I want them to do, condition specific, where is it? Close. So I can definitely recommend that you start off with protocol B. Somebody's really, really hot. You want them to actually start off with intermittent gradual distraction, like protocol B, which really keeps things nice and calm. Do that for the first 4 visits if it's appropriate. Then condition specific progression protocol, CPT codes. I'm looking for my protocol list. Hey, Liz, could you print that out and bring it to me? That'd be great. So protocol B was where I'd start somebody who's really, 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 really hot, okay? And then I'd move them, especially if they have right leg sciatica, I'd move them protocol K. Protocol K is actually going to do axial distraction, and it's going to move feet left, opening up the right IVF, and it's going to do gradient traction out to whatever you set. So if it's set at 3 inches, it's going to gradiently distract center, and then it's going to move feet left, gradiently distract. So protocol K. I would then move them to a bilateral movement if it's appropriate. So once you start shutting down the right sciatica, I would start looking at adding more inches. So probably visit 12. Do a reassessment, add another ½ inch, and if it's appropriate, then move bilateral, okay? So Dr. T asks, patient has spinal stimulator, elderly patient, chronic pain, contraindications. The stimulators are not much, you really, contraindications there are going to have more to do with osteoporosis, osteopenia. The stimulators are not going to create too much of an issue. Okay, they're actually shutting down pain and creating some issues. So if y'all, thank you, Elizabeth. So if y'all have any questions specific about, look, if anybody doesn't have this protocol list, it's on the online resource center. Okay, it's a graphic. It shows you exactly what's happening. So protocol B is going to show you it's a gradual out. All right. Now, I moved to protocol K, like I was talking about. Again, it's going to be gradual, and it's going to move out gradually. All right. So this list is very, very important. Go on to the back on Trac, Ergo-Flex Technologies website. Go on the online resource center. You have to have a password. It's for owners only, and this information is there. I keep these by my adjusting table when I was in practice, and I kept them by the back on Trac tables so that we had a specific reference as to what I was wanting to do. I use 5 mainly, but when I wanted to do something very specific, I would. Dr. Evans, hello, hello. It's nice to have you. If you have any questions, please chat me up, hit me with a question. So, Jared, right leg, I got you. Okay. So, again, I like the progression protocol. Again, you go back on the website and you look at the progression protocol. I've got several things. I've got the actual CPT codes listed on there for what they should be used. The back on Trac progression talks about actually what we are doing right now and talking about how to actually increase and create a progression protocol throughout. None of my patients, a lot of docs, look, a lot of docs basically, everybody comes in, they get 3 inches, protocol M or protocol U, and they never change it, okay? I honestly recommend that you don't do that you use the full extent of the back on Trac. It is the only system that has automated lateral, unilateral, and bilateral, intermittent axial distraction, static traction, sweeping mechanisms. Use all of them, all right? And if you do it correctly, what actually happens is that patient knows that in 4 visits, there's going to be a change, all right? And this is exactly how you handle it. Say, hey, Mrs. Smith, I see that your pain going down your right leg's much better. That's awesome. So what we're going to do is on your next visit, I'm going to change the back on Trac into how it's actually working because you're doing better. And a lot of times what I see is that patients start to say, it doesn't feel like it's doing as much as it used to. That's your body getting used to the treatment protocol. So I'm going to add a 1/2 inch. You're going to feel that, okay? And then I'm also going to have your feet move left. You're having pain down that right leg, I'm going to move left, okay? We're going to do that probably about 4 visits. And then we're going to move on. Dr. Ballerini, hello, hello, hello. Hey, everybody, thanks for showing up. If you have questions, please ask me in the chat. Raise your hand. If you have a microphone, ask a question. I'm happy to answer. But the progression protocol, it's an amazing thing because what happens is patients start looking for being able to actually, for the change, okay? If anybody has used a poundage-based system in spinal decompression with the big strapping, what do they say? They say, I want more and more. You can pull harder and longer, pull harder and longer, all right? They get fixated on how much poundage has actually been used, and then they want more and more and more. Change is actually what they're seeking. They want to know that they're making improvement. Hey, Dr. Offling, it's good to see you. If you have questions, please write it in the chat section. I'm happy to get to them. Dr. Tiffany Miller, how's it going? I want to make sure you're doing good. All right. I know that your machine was making a funky sound that was actually not a funky sound, but it was doing good. I was just making sure everything's good there. Dr. Drinko, Callan, Clancy, I got Mercedes. She's on, learning. Dr. Anderson, Dr. Linda Anderson. We should call her doctor. Let's see. Okay. Great, Dr. Miller, awesome. Love the machine. And she's talking about the knee on Trac as a total game changer. And I know we're talking about back on Trac, but here's the reality. The back on Trac and the knee on Trac are absolutely perfect tools that go together because if you got back pain patients, guess what? You got knee pain patients. They're just not talking to you about the knee. And so it is an absolute game changer. You are correct, Dr. Miller. It will take you to the next level taking a look at coupling the back on track and the knee on track. You want to take it even to a greater level than that, add the total brain and body O2. Everything in your body needs needs oxygen in order for it to regenerate and heal. And we can actually make that happen with total brain and body O2. So, but the back on track progression protocol. So the patients really crave, they want to know that they're getting better, okay? And one of the best ways to do that is to change their protocol. So every 4 visits, I change the protocol if it's clinically appropriate. And I'm always moving towards protocol U. That was my if it was appropriate, I'm moving everybody to intermittent, axial, and bilateral distraction, okay? 20 degrees of bilateral movement, right and left, with distraction. It is one of the most powerful protocols that we have. And like Donnie pointed out, because Donnie has a spondy, I hope you don't mind me saying that, Donnie. Guess what? I've got a spondylosis too. Those patients do really well with protocols M and O, which is the sweeping mechanism. Any other questions? Come on, guys. I got a little bit more time to fill up. Any contraindications? There's a great question about the neurostimulator. Oh, let me talk about spinal fusions. If you're not treating spinal fusions with the back on track, you are missing out. Okay. Now, there's some caveats to that. That spinal fusion needs to be at least a year old. Okay. And I'd say that because I don't want any hidden infections to pop up on us and have bony failure because of that hardware. Okay. It is a rare event that the hardware fails itself. It usually has something to do with the bone. All right. And so if you've got a hidden infection, bacterial, viral, or fungal, guess where it likes to hide? It hides right between the bone and the hardware. It wants to be right next to that metal. So that's why they at least need a year, or if you have surgical surgical approval from the surgeon says, hey, yeah, you can go ahead and get him going with this, then you're in good shape, okay? So look, 90+% of the nutrition that occurs in the brain happens because of the cerebral spinal fluid pump, all right? Well, when you fuse a segment in the spine, guess what you're doing? You're shutting down movement of the spine. You lose anywhere from 10 to 15% of the movement of the spine when you fuse it, when you fuse a segment, all right? So that means you're not moving as much CSF to the brain as you need to, which basically means that the brain needs CPR. So we need to pump. And when we pump with lateral, bilateral, axial movement, and axial movements, it's actually resetting that CSF pump. Very, very powerful change for patients, because we know that fusions, guess what? If they do an L5S1 fusion, the next one that's going to get fused is going to be L4, and then L3, and then L2, and then L1. It's proven time and time and time and time again, if you don't keep the movement in those segments, they will fail, because they're having to pick up all the extra movement with the neuromuscular skeletal dysfunction that's occurring because of the surgery and the fusion. You need to be, those patients need to be on the back on track, because there is not anything that I did on a regular basis in a chiropractic adjustment that I created decompression in the spine. Side postures don't do it. SOT doesn't do it. Flexion distraction will do it on some level, but it does create quite a bit. I mean, that's a lot of wear and tear on you. I remember doing 25 to 100 pumps on a patient. Boy, that's a lot of wear and tear on me. So tell you what, target your patients that actually have fusions, okay? They're gonna love this thing, especially if you do it right. Now, you don't wanna use a real aggressive protocol, okay? You don't wanna stretch them out to 5.5, 6 inches. You don't want to, okay? That's not what you're there for. You're there to get things moving, all right? And the back on track does that beautiful job of that, actually getting things moving. Very, very, very powerful piece of equipment. Christina. Another question here. Go away, please. There we are. Aha. Dr. Cross. Uh-oh. And AC. When were you discussing blocking or scoliosis? Apex of the curve. Can you elaborate? Sure. So it gives me a chance to go back and talk about this a little bit more, a little better. So first of all, you need to find out if you have functional structural curves. All right, scoliosis may have a structural curve. It's not going to move. All right, if it's not moving very well one way or the other in lateral bending, on your lumbar X-rays, you need to figure out what you're going to do with that. That's probably going to be more of an axial distraction. Okay, so let's say we have a left convexity. So we got a left curve in the lumbar spine with an apex at L3, right? So that means that when you take a look at their X-rays, when they're standing, their hip is actually shifted, which means that their feet are going to want to move to the left if they're laying on top of the back on track. Okay, that's going to be their natural position based on that scoliosis. So on the right side at L2 at the apex, you're gonna block. Okay, and then you're going to use a protocol like K, or you're going to protocol. Let's take a look. K is going to be a good one. Because the feet are going to move right in that instance. All right. Protocol H. No, excuse me. Protocol H and protocol I, and then protocol E. So those are going to move feet right. So you're going to move into that curve, right? So you're going to straighten out the curve, and you're going to be blocking at the apex. All right. Now let's say you got an S curve that goes all the way up into the thoracic spine. So they got a left convexity with an apex at T8. So you're going to block on the left side of that convexity. Yes, the left side, and then on the right side at the L2 convexity. All right. And on that one, I'm going to do start them off with a straight axial distraction. Okay. And 4 visits, see if it's appropriate to move them into a bilateral movement. You got an S curve, you want to be moving that both ways because you're going to be working that neurologically both ways. So you got to work out, you got to work certain things. So like the QL needs going to have to be lengthened and strengthened at the same time. And the back on track does a beautiful job on that. Dr. Shelley Drenko. We have eval responses for our peripheral neuropathy patients. Most of our PN patients visit their favorite machine in our office. Oh, wow. We use protocol N or O usually. Most of the docs do, okay? And that's why they do a fantastic job, okay? And it depends on the patient, right? So N and O are great protocols, but we have 21 total protocols, and it just makes all the difference in the world. So N and O. So N is static axial, and then sweeping bilateral, it starts in the middle. Same thing with protocol O. Okay, but we either use 20 degrees or 20 degrees, so on and so forth. So the back on track basically will move 10 degrees laterally or 20 degrees laterally for a total of 40 degrees of movement. I'd like to see a little bit more. JT is working on that. We may even get up to 30 degrees, but there are some blocking techniques that you could do. So if you want to get it a little bit more, you can actually shift the hip. So let's say you want to get more movement to the left, you shift the hip to the right with SOT block, and you block under the PSIS. Any other questions, guys? We're almost time's up. Dr. T. Hold on here. Why am I not seeing this message? Aha. Dr. DeSalvo. Do you prefer static N or O or intermittent program T? I prefer, it depends on who you're talking, what you're talking about, okay? So I always prefer taking a patient to the intermittent axial. All right, my goal is always to move them to protocol U, but T is a great protocol. Yeah. T is a 10 degree and U is the 20 degrees. So I'm always trying to move them towards an intermittent aspect. Hey, you know, there's some of those. Use SOT blocks or something else. SOT blocks, Dr. Evans. That's pretty much what we use. Dr. Ballerini, we no longer sell those. Oh, the Saunders unit, yep. So that's one of the other questions. Did I not see that? Dr. Ballerini, what'd you ask? I don't see it. That's okay. Yeah, the Saunders unit. I used the Saunders unit for several years, and we're currently working on a neck on track attachment that actually goes on the back on track, which is very interesting. It's a hybrid. It's going to be hybrid. Okay, it's actually going to do curve restoration and axial distraction at the same time. If any of you've had any experience doing cervical axial, intermittent axial distraction, the first thing that happens is they lose the cervical lordosis. Okay, so I started doing protocols like CBP with the dental roll, and as long as the patients were compliant, things were good. But patients are not very compliant when it comes to the dental roll. That's just the reality of it. So what happens, they lose the curve, you fix the disc, but 3 to 6 months later, they're back in your office, the exact same problems that you fixed them with. And it's going to be something, the neck on track is actually going to be an attachment that will retrofit directly to the back on track. You're not going to have to buy a whole nother back on track just to do cervical. That's going to be the wonderful thing about it. It's in the works. We're on iteration 6 now that's in planning. We keep working on it, we just got to make it perfect. Any other question, guys? Why do I have this? What is going on here? All right, I'll tell you this, if y'all need any equipment, we're here to help. Okay. And I was talking to JT and Thomas yesterday, and one of the things that we are very proud of is that since we started our program with actually doing financing, we've had 100% placement rate. In other words, if you got great credit, if you got iffy credit, you got questionable credit, if any of those things are in play, then we will be able to find, most likely, I'm not going to give you 100% guarantee on that, financing that is very, very affordable for you. Okay. And the great thing is that most doctors absolutely get the return on investment within the first 1 to 2 months, pay it off because there's no early payment fees. There's the Section 179, there's the ADA tax credit. There's a tremendous amount that you can do with this piece of equipment that will help you absolutely take you to the next level. Dr. Penrose, 30-degree lateral flexion would be great. Yes, I agree. It is what's coming. I actually would like 45, but we're working on it. We're heading in the right direction. When we start recalibrating and reworking how the back on track actually works, it's a complete re-engineering process. Okay, so just be patient, and there are some things that you can do. Okay, so like I said, if you and I've been working with Dr. Hassler on, he's actually got a problem, and there were some very specific protocols that he and I talked about that he's treating himself on the back on track, and so there were some very specific things that we were doing for him with the SOT blocks that has made a big difference for him. He was having some issues. We had to put him in extension before we could actually do the lateral distraction with him. So again, if you have questionable credit or you don't want to tie up your credit cards or your cash flow, we have a wonderful financing options. 100% placement is what we've had in our track record. We can make it happen for you. And I can tell you this, we can make it happen if you have any questions. All right, guys, any other questions, I'm happy to answer. If you have, if you're taking a look at the knee on track to couple in with the back on track, I highly recommend that. If you're doing any type of metabolic medicine or regenerative medicine, definitely take a look at Total Brain and Body O2. I have a 5-minute depleted protocol for that. That actually means that it only takes 5 minutes for your patients to get the benefits of O2 and increase their capacity over the long run. It is an amazing protocol. It's not a 15-minute protocol. It's a 5-minute protocol. Now we're talking about something that you could actually apply to every chiropractic patient that comes in your clinic, because oxygen and hemoplasticity is the foundation of regenerative repair in the human body. If you're not oxygenating and perfusing your tissues, you're not going to regenerate worth a darn. Very, very important. All right, guys. Any other questions? If not, we're going to tap out. Hey, next week is going to be Q&A on Total Brain and Body O2. Week after that, we're going to swing back. Hey, Dr. Haskell, we were just talking about you. And Dr. J, hey, you have any questions? Post real quick. I'll answer anything. I know we just popped in. Happy to take care of you. Awesome, awesome, awesome stuff. We're talking about how we can use the SOT blocks, and I'm going to put some protocols together for that. I need, actually, you know what? Ooh, Dr. Cordova, I have not made that video for you. He asked me specifically on a video on how, how to use the SOT blocks on the back on track. It's pretty simple. It's not the end. It's not that hard. It's actually exactly what you think it is. But I can put some videos together for y'all if that's something you're interested in. All right, guys. Awesome. Don't forget, next week is we're going to swing back around to, no, we're going to Total Brain and Body O2. And then on the 13th, which we'll do our knee on track Q&A on the 12th, but then on the 13th, we're going to have a special webinar. That's Thursday. It's going to be at 1 o'clock, and it's going to be specific to sales, okay? How and what you need to say to your patient as to what you're doing in your value stacks, how you actually explain this thing, explain the knee on track, the back on track, and Total Brain and Body O2 in a way that gets patient to take action right then and there. Very, very valuable tips. And September 27th and 28th, Secrets to $1 Million Practice. All right, guys, this is going to be our fall bash. If JT gets his way, we're going to be giving away a ton of stuff, okay? We're going to be giving away equipment. We're going to be giving away cash. We're going to have some great speakers, Dr. Tony Ramus, Dr. Andy Barlow. I'm going to be speaking specific of knee on track, back on track, and Total Brain and Body O2. We're going to have some great practice management. We got Dr. Frogley coming in about Blue IQ on how to actually get the administrative side of your practice up and running. So I can't stress enough, September 7th, 27th, and 28th, Secrets to $1 Million Practice here in world headquarters at Conroe, Texas. Guys, you got to get here. It's just going to be amazing stuff. We've got special giveaways. If you bring a doctor that doesn't have our equipment, you're going to get some extra special treatment on that. It's just going to be a big, 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 big party. Okay. And JT is all excited. Linda's really excited about it too, but not as excited as JT. All right, guys. It's been great. If you have any questions, shoot me any questions that you may have at dr.wyatt@backontrack.com. TRAC without a K.com. All right, guys. Great having y'all on board. Y'all keep saving lives.